Well, hello and welcome everybody. I'm going to go ahead and get started in efforts of everybody's time. Welcome to today's ECHO session with the Institute on Disability Research Policy and Practice Project Scope. We're really glad that you have joined us today. As you know, we are recording these for educational and quality improvement purposes. So by participating in this session, you're consenting to being recorded. ECHO is, as you all know, is this interactive community with presenters, stakeholders, and all community members. So please be sure to turn on your cameras. We want to have an interactive conversation and community practice about this. We also are wondering and looking for case presentations. So it is a really great way to solidify our information. If you have a case that you would like to share with us, please reach out to Project Scope at usu.edu, and we would love to take that into consideration. When we're talking about anything today, please remember to protect any individual privacy. So avoid using any identifying markers, situations. If you have any questions, reach out to one of our hub members. Each of our hub members has an asterisk in front of their name, so you would be able to find out who those are. If you will also rename your profile, so your name, where you work, and your discipline, so that others could reach out to you. We have pre-registration for any of our ECHO sessions. This is a 10-week course of Project Scope, and if you want those materials ahead of time or would like to know what's coming on, please reach out to Project Scope at usu.edu and register for those. We have a certificate of attendance. There's an evaluation that is going to come out to each of you after the session. When you complete that, we will send you a certificate of attendance. And then I am also going to turn it over to, oh, I thought I put it in there. Jared, I thought I did, but I pulled up the wrong one. So tell us about our continuing ed.
Yeah, we're okay with that, the slide. Thanks, Janelle. So University of Utah Health, we're just so pleased to partner with USU and Project Scope. And on behalf of our new mentors, Dr. Jennifer Goldman-Luthi and Mindy Tuller and everybody else, thank you for letting us be here with you today. And it's so nice to see so many names with that. I've missed you guys this past summer. Long story short, we are offering CME credit for today's event. I'll put it here in the chat. Here's the CME code for today, 233195. Note that down. Now, there's two things you need to know. In essence, one, you need to claim CME today. Do not delay. Do not let the opportunity pass. This opportunity evaporates tonight at midnight. So please claim CME as soon as possible. The second thing to know is that sometime in the next hour or so, you will receive a detailed email that will have all the instructions you need to claim CME. If you don't have a transcript at U of U Health, you'll need to open one. It's not hard, but you do need to have that. So please do claim credit through the University of Utah, and that's applicable to anybody here in the Mountain West or beyond. If there are questions about that, please reach out to me by email and respond to what I send out. That's it, Janelle. Thank you.
Okay, great. Sorry, I'm not sure why I don't have that slide in there. For those that are new to ECHO, just understanding that the key components of an ECHO session is really building that community of practice. So sharing all of our knowledge with everybody that is out there. We will have a didactic speaker as well as a case presentation. So a case narrative that then we will do small breakout groups so that we can provide some resources or information based on the case presentation. We would love it if you in the chat do one reflection from the session or one thing that you might add to practice as you're listening to our fabulous speaker today. All of our materials for the Institute for Disability Research Policy and Practice is on our Canvas site that you should have or will be getting an invite to in the next few days with it. There's a discussion board that is another option to continue to connect with other participants from the session. Our red cap is our survey data collection, which is where the survey will be coming. So please double check your spam or junk email folders. Case studies, once again, are just another way for us to share and learn real life situations. So if you have a case presentation or narrative that you really want to brainstorm with us, please reach out to us at Project Scope at USU and see about doing that. We have a Facebook page as well as an Instagram that we do share information on. So I'm really excited today to introduce Dr. Marcela Smid from the University of Utah. And one of the things that she said in her introduction is to say, if you email her and she doesn't respond within a few days, reach out to her again, but never email her on Tuesdays. So without further ado, I am just going to turn it over to her to start her amazing presentation. So let me stop sharing.
Good morning. Yeah, I have Super Ad Clinic, which I'll explain what that is momentarily. Okay, you guys, let's see. Let's make sure I can. Okay. Oh, yes, slides are up.
Okay, yes.
Perfect. So thanks everyone for the introduction. Thanks to Nell for the introduction. So I'm Marcela Smid. I'm a maternal fetal medicine and addiction medicine doc up at the U, and I'm the medical director of the Super Ad Clinic. So we're going to do a whirlwind of pregnancy for women with substance use disorders, a review of the important things I think you should know. So this is very much a sampler, and each of the 4 objectives that we're going to go over could actually be a talk in and of itself. So please, please, please interrupt, put things in the chat. I know there's a couple of people that are going to be monitoring the chat. So if you have questions, likely everyone has questions, and it makes it a little easier if you ask the question at the time. So I know we're all on lunch breaks and you may get pulled to your next thing. So my only disclosures are that I am on the medical advisory committee for Gilead Science, and that's for hepatitis C treatment for pregnant and postpartum women. And I was funded by an NIH K-12 grant from 2018 to 2020. And so I mentioned I'm the medical director of the Super Ad Clinic. So that is a specialty prenatal and postpartum clinic for women who have substance use disorders of any kind up at the U. The co-director is Jasmine Charles, who you see here on Super Ad's first birthday. Super Ad is now 4 years old. Its birthday is, we do refer to it, we anthropomorphize it and talk about our 4-year-old now. So we've got a 4-year-old on August 4th. And these are the things that we're going to go over today, which is identifying brain changes related to substance use disorders and addiction and how it impacts one's behavior. We'll very briefly describe evidence-based practices for the treatment of substance use disorders in general. I'll spend a little bit of time talking about medication for opioid use disorder and how it's approached for pregnant and new moms, and then identifying major challenges related to treatment, and then return to use among pregnant and postpartum women. Okay, so first things first, what is addiction? I think that this is, if you remember nothing else, these are going to be the most important slides. All right, so let's start with what is substance use? So substance use is the consumption of any psychoactive substance with or without adverse consequences. Misuse is using those substances excessively. So that can be alcohol, pain medications, illicit drugs, and that may lead to either social, physical, or emotional harm. So that's like, drinking. So there's the difference between drinking a couple drinks at night with dinner versus binge drinking on the weekend and then waking up with a hangover. And then these are things that addiction is not. So tolerance, so physiological adaptation and diminished response to substance after repeat uses. So that's so for example, talk about opioids. If any one of us took opioids and we stopped taking it abruptly, even after as short as 5 to 7 days of taking it every single one of those days, you may feel withdrawal symptoms, which is your physiology adapting to the presence of that substance. And that's physical dependence. So there are characteristic syndrome, characteristic class-specific withdrawal symptoms that you may get if you stop abruptly. And each substance is a little different. So benzodiazepines and alcohol look more similar to each other than they do to opioid physical dependence versus methamphetamine physical dependence. And then psychological dependence is the subjective feeling that you need that substance to feel better, either to feel better or to avoid feeling bad. And so that might even be something like, I got to go have that cigarette in the middle of the day. I'm really on edge. I'm really anxious. And I'm just going to feel better if I do. Those physical and psychological dependence are interrelated, but the subjective need is that I feel like I really need it, is the psychological dependence. So then what is addiction? So addiction is a primary and chronic disease of the brain, and it's highlighted because I think this is super important, of the reward, motivation, memory, and related circuitry. And it's the dysfunction in these circuits that leads to the characteristic biological, psychological, social, and spiritual manifestations that we know of as addiction. So behavior is actually a symptom of the condition. And we're going to go over that and the different parts of the brain that are affected. And this is reflected in an individual's pathological pursuing of the reward or relief of symptoms by substance use and other behaviors. So what do I mean by that? So the primary neurotransmitter that we talk about is dopamine. So that is part of the way that we feel pleasure for anything. So food, sex, any sort of pleasurable activity. And things like, for example, here, cocaine make our neurotransmitter or our synapses release more dopamine. So you get this really intense feeling of wellness, especially the first few times that somebody does a psychoactive substance of any kind. And what you see down below are the functional MRIs, where you see a person who does not have a cocaine use disorder, a person who has cocaine use disorder once they've stopped cocaine use 1 month after, and then 4 months after. And what you're seeing is the red highlights are the nucleus accumbens and ventral tegmentum. No quiz at the end, but what I want you to remember is that it really takes a while for those dopamine receptors to come back. So they do come back. There is treatment, and your brain does recover from addiction, but it takes a long time. And we can truly see physiological changes in the brain. So things that make me crawl up the wall is when I hear things like addictive personality, right? There's no such thing as an addictive personality. There's a physiology that underlies addiction, and some people are more or less susceptible to that physiology based on both hereditary things and environmental things. So there's 3 parts of the brain. There's the basal ganglia, that's that nucleus accumbens and ventral tegmentum. That's the area of the brain that's involved in positive reinforcement. So that's where that dopamine acts. And that's really where cravings and triggers live. The second part is the extended amygdala. So that's where that negative reinforcement happens. And that's mediated by other neurotransmitters like CRF and dysnorphin. And this is the extended amygdala interacts with the basal ganglia, and it decreases that reward activation. So as you use a substance more and more, you get less of the reward every time, right? So there's less dopamine that's released, and that's mediated partly by this extended amygdala. And the drive there that the amygdala drives is to alleviate negative feelings. So it's when you have anxiety or feel, and it's the compulsion to use. This is where the compulsion to use a substance to get rid of the negative feelings lives. And then the prefrontal cortex is where our executive function lives. And you have compromised executive function once your neurotransmitters have really, and your circuitry is really remodeled. And that's mediated by glutamate. And this is where habits live. So there's an overactivation, there's a go and a stop system. So the go system helps us make decisions, and the stop system regulates that. And what happens with the prefrontal cortex with addiction is that go system is overactivated, and your stop system that says, no, don't do that, that's a bad idea, is underactivated. And that's where compulsion and impulsivity live. And like I mentioned, there's vulnerability to addiction. So that's the pathways that get altered when you have an addiction. And there's 50% of what we think of as genetics or really hereditary. There's a component, and that is whether or not you have certain kind of opioid receptors. You may have a certain polymorphism. What does your dopamine signaling act like? And when we look at a pedigree of somebody with a substance use disorder, it looks very similar to that of someone with a chronic medical condition like diabetes or high blood pressure. So a lot of first degree relatives. Often it's not just genetics, but it's also maybe the environment, right? So that's that other 50%. And so we don't know whether you do get your genetics from your parents, but you also are living with your environment there. So what does your family structure look like? Do you have adverse childhood experiences? Psychiatric disorders put people at increased risk of developing substance use disorders. What's the environment? What's the access to substances? Some people have more or less access. So those are the components of what creates the vulnerability to developing an addiction. The most important slide is infants cannot have an addiction, right? So they can have a physical dependence, they can have withdrawal symptoms, but they cannot have an addiction because their neurocircuitry is not remodeled in the same way, and they do not meet criteria for having dysfunction in those circuitries because theirs is not yet developed. They can have neonatal opioid withdrawal syndrome, or that's specific to opioids, and these are the symptoms. I know that you've had other echo sessions to cover the identification and management of that. We try to use NOWs for opioids and NAS or neonatal abstinence syndrome for other substances. And then the definition of a substance use disorder. So you can take any. So these are the DSM-5 criteria. So I started with substance use, and then this is how you diagnose a substance use disorder. And I encourage you to use the word substance use disorder and not substance abuse. And I'll talk about that in just a second. So in the past year, you have to have 2 or more symptoms that result in distress or impairment. And that's really the key here. So you'll see that middle section of physiology of tolerance and withdrawal. So you cannot just meet criteria by that. So for example, if we go to the Huntsman, there may be plenty of patients who are taking opioids for pain management during their cancer treatment. And they would have tolerance and withdrawal symptoms, but they don't have a substance use disorder unless they have some other symptom, such as loss of control, taking more than intended, unable to cut down, giving up on activities, or having cravings, or some consequence, so unfulfilled obligations, interpersonal problems, being in a dangerous situation, or medical problems. And so you have to meet one other symptom to really meet the criteria for substance use disorder. Now in pregnancy, it's thought that if women are using substances, essentially in the second trimester, certainly in the third trimester, that is essentially pathognomonic for a substance use disorder. So we most frequently see that, for example, with smoking tobacco, right? So if someone is smoking in pregnancy, because 100% of pregnant women know that smoking is not good for them or for their baby. And almost all women will try to at least cut down. And if they're not able to stop, it's essentially pathognomonic of a substance use disorder. And then I encourage you to use this diction of addiction and using person-centered language. So we often see an addict or abuser, heroin abuser. I really encourage you to change your language and to use person-centered language, especially with addiction, because there's so much shame and blame with addiction that often a person doesn't see themselves as anything other than the addiction. And that's for good reason, because a lot of times society has said the only thing that defines you is your addiction. So really using person with a substance use disorder. And then one of the most frequent things that I see is clean or dirty, and this gets used a lot. So if someone is clean, we will use that as a term for sober. And I would encourage you to really get away from that. So it's not, we say less. So dirty urine, it's positive or negative, expected or unexpected. Because when you're calling it clean or dirty, you are implying that a person who is using drugs is dirty. or less than. And that contributes to the stigma and to the shame of this medical condition. And so these are some terms that we are trying to move towards. And you'll even see medication-assisted treatment is one of the most frequently used. And we see that consistently in the public media. We see that even in the literature now. And we're really trying to move towards medication for opioid use disorder or pharmacotherapy, because the medication-assisted treatment implies that medication is not treatment, and it is. It's fundamentally one of the most important things, particularly for opioid use disorder. Okay, so now I'm going to move into evidence-based treatment for substance use disorders. So this is in general. So this is sort of the continuum at the top. You see, this is from the surgeon. There is a link on a preview on I think the next slide, if anyone wants to read more. The Surgeon General put out a paper a couple years ago on addiction, and it's really very good. It goes over addiction treatment, how we talk about it, what terms we use, the neurobiology, and goes over the different treatment types. So at the top, you see the continuum of what we refer to substance use, substance misuse, and what's a substance use disorder. And then at the bottom is that continuum of treatment. And so we start all the way on the left, which is enhancing health, right? So that's really promoting optimal physical and mental well-being and free from substance misuse. So it's important to make sure that you rewrite, it's not necessarily free from substance use. There are people that utilize substances like alcohol, for example, but that we assure that it's not creating adverse consequences for somebody. And so primary prevention is addressing those individual and environmental factors with substance use through evidence-based policies and strategies. That is a lecture in and of itself. So I'm going to focus on early intervention treatment, and then we're going to just briefly touch on recovery support. So early intervention is really screening and detecting substance use. So that's at that patient level. Is we can't do anything about it if we don't know about it. And I'm going to talk about screening and how to do that in just a second. And then treatment, there's a spectrum of treatments. And that goes from outpatient services, intensive outpatient services, residential or inpatient, and medically managed inpatient intensive services. And people can move through that spectrum all the time. One of the most important things to remember is that it often takes, much like diabetes management, right? So the mainstay is outpatient treatment, right? So if you have someone who has diabetic ketoacidosis, you admit them to the hospital, you stabilize them, right? You would of course try to link them with an outpatient provider because their diabetes is going to need management. This is really the identical approach for substance use treatment. So when we admit people in the hospital, which we do for pregnant individuals here at the U all the time, for example, for opioid use disorder, we stabilize them on Suboxone or on methadone. The linkage to that care, right, is so important because you need an outpatient treatment provider to really provide that continuity. And then recovery support is facilitating peer recovery support, facilitating the ability to live a full life free of substances, if that is what somebody wants. And really, it's not just the freedom from, it's not just the absence of substances, it's the absence of the adverse effects of those substances. So screening, many of you heard about SBIRCH, so screening, brief intervention, referral to treatment. So screening is really important. So for pregnant women, it should not be based on risk factors because risk factors are fundamentally classist and racist. So when we know that when we leave folks to screen based on risk factors, disproportionately poor and minority women will be screened. And we know that addiction and substance use disorders in pregnancy are across the board. They go across all class and racial categories and really all sectors of society. So these are 3 examples of screening tools. There's not one that's any better or worse. What's important is to find the tool that works well in your setting and what are your providers going to do. The brief intervention is often based on motivational interviewing, and it's eliciting own goal setting of a patient. So it's, do I see this as a problem? Do I see, what are my goals? What do I want to do? And then really referral to treatment is if someone likely has a substance use disorder, or really severe substance misuse, is referral to treatment is that last piece. And then often I get asked, well, how my patients don't want to be asked those questions. And I'd like to dispel that myth, because what we know is that there's patients do expect to be asked. We screen people with blood pressures to prevent stroke, right? And Melissa Chang is a colleague of mine who does a fantastic talk about this. She talks about how, we all expect to go to the doctor and have our vitals checked, right? And this is the same, you're more likely to catch substance misuse and substance use disorders if you're screening people. And one thing to do is to ask permission and to open that door and say, is it okay if I ask you some questions about smoking, alcohol, and other drugs? And if the answer is no, then you say, okay, then we'll ask you the next time, say, okay, I hear what you're saying. I'm here to discuss it if you would like to, and then screen them the next time, and avoid really closed-ended questions like, you don't smoke or use drugs, do you? And then, especially for maternal and infant health, I want to stress that your UTOXs are not screening. They're not recommended by ACOG to be done as a substitute for screening. They have very high positive and high false positive and false negative rates. And really, the reality is many providers, the vast majority of providers, don't understand how to interpret the results that they're seeing. And there's a difference between urine screening and confirmatory testing. And that is, I have a lecture by itself about how to read a UTOX and what it does and does not tell you. And really, it should only be done with consent. And again, to the point for my first talk, is really not referring to it as clean or dirty, expected or unexpected results. And then one of the most important keys that you as a provider or early interventionist is harm reduction. So for moms, it's outreach and education. So really, that's a primary, so a public health intervention is really to say, the opioid epidemic is everywhere, and taking pills and heroin are not that different. There's harm reduction strategies such as needle exchange, which reduces HIV, hepatitis C, and other infections. Overdose prevention education, access to naloxone, and even fentanyl test strips, which I like to joke with our patients that were clearly designed by a man, because 2 lines for a pregnancy test is positive, but for a fentanyl strip, it's actually the opposite. 1 line means that there's fentanyl. And so these are the principles of effective substance use treatment. I'm not going to read this laundry list for everyone, but really the things I want to highlight is that addiction is complex, it's treatable. There's not a single treatment is appropriate for everyone, and treatment needs to be readily available, which we know it is not for all individuals, particularly for pregnant and postpartum individuals. And that medications are a really important element of treatment. And that can be alone, and it can be even more effective when combined with counseling and other behavioral therapies, but it shouldn't be medications, particularly for opioid use disorder, shouldn't be based on the requirement that somebody is engaging in behavioral treatments. And then discrimination and stigma are really prevalent in substance use and substance use disorders in pregnancy. That goes from the stigma and shame that we place on women who are utilizing drugs, the availability of resources specifically designed for pregnant and parenting individuals, including residential treatment programs that allow and really facilitate and embrace having your existing children with you. And then respecting patient autonomy. That's off. When a pregnant woman is utilizing substances, that is often compromised, for example, with the increased incarceration rates that we see for substance use criminal charges. So for many people who are incarcerated, either in jail or prison, they are often released if they're not pregnant or postpartum. But women who are pregnant or really pregnant are disproportionately held for their own good or for the baby's health. And that is discrimination against a pregnant individual. We shouldn't hold someone incarcerated just because they're pregnant. And incarcerated treatment, fewer than 5% of women get substance use treatment when they are incarcerated. This is actually, we are very lucky at the University of Utah. So the Super Ad Clinic partners with the Salt Lake County Jail, and Jasmine, who you saw in the picture, sees all pregnant women who are incarcerated in the Salt Lake County Jail and facilitates treatment for substance use disorders, including opioid use disorder. And then we really need to just at least acknowledge that the way that we've approached pregnant and parenting individuals in the past, and it is certainly getting better, but really with systemic racism in terms of substance use disorders. So this is an Office of Inspector General 1990 report that is entitled "Crack Babies," right? And I mean that is a shame. That's a term that's laden with shame. And we need to acknowledge that our Black and Brown communities were discussed in ways that we don't talk about the moms and babies in the opioid epidemic. And that is not, and it is because the opioid epidemic it disproportionately, or at least in the past, disproportionately has impacted white communities. And so we see that the terminology has really been humanized as the opioid epidemic has developed and then white individuals are impacted. And we need to acknowledge that that was not afforded to Black and Brown communities in the cocaine epidemic. So medications for opioid use disorder among pregnant and parenting individuals. So the most important thing I want you to take away from this slide is that medications for opioid use disorder during pregnancy and postpartum are protective against overdose, right? So it's not just during pregnancy, it's really also in that year postpartum that we need to be counseling moms about their risk of overdose. And this is that tip of the iceberg, right? So overdose is just the tip of the iceberg that we can see. But when moms are not continuing on medications for opioid use disorder, they're much more likely to return to use because they're untreated. And detox, so when I say detox, in this, I mean a taper to tapering a medication or tapering down or detoxing, so getting through that acute withdrawal period after a rapid stop of use, but not treating folks with medications. And that does not decrease neonatal abstinence syndrome, and it increases the relapse risk, and it's not recommended. So then what are the mainstays of medication for opioid use disorder treatment? So methadone and buprenorphine. So buprenorphine is in here. The chart shows the mono product, but really we utilize in SuperAd the combo product. So we utilize the buprenorphine and naloxone combo product. So it has the same efficacy as methadone. It has the same adverse effects of methadone. Because of the way that the buprenorphine works, there's actually a decreased risk of overdose because that buprenorphine is occupying that receptor. And if someone has a return to use, they are less likely to overdose because their opioid receptors are occupied by the buprenorphine. There's fewer drug interactions, and there's less frequent neonatal abstinence syndrome and milder symptoms in neonates. And for the neonate, there's a decreased need for morphine dose required to treat that neonate, shorter hospital stays and shorter duration of treatment for the neonate. Methadone has to be given in an outpatient treatment facility, so the methadone clinic. And often that comes with a structure, it comes with a therapist, it comes with often wraparound services that some patients may need. And there is a decreased risk of diversion, and there are longer term outcomes. The thing that I want to point out is that one is not better than the other, and we should not be switching somebody who has been on methadone for a really long time and been stable to buprenorphine because of the perceived neonatal benefit. The benefit is maternal stability. And by taking somebody off or transitioning them from something that is working to something that may potentially work is not recommended. Now, have we had patients that switched? Absolutely. We've absolutely transitioned patients, but that's after a very long conversation and really looking at their situation, their social support, and we make plans of, well, if this is not working, so for example, if someone starts to decrease their methadone and they start to have cravings, findings, and we still have a ways to go, that may not be the best thing because we are eliciting the symptoms of their substance use disorder. And naltrexone is a complete antagonist. We have limited data in pregnancy, but we have emerging data in pregnancy for its safety. The difference between with methadone and buprenorphine that are a complete agonist and a partial agonist and naltrexone is that you really need, for opioid use disorder, you need at least 10 to 14 days of non-use. That really limits the population that this can be used in. And it's often used in folks who are incarcerated, that they receive naltrexone, they receive an injection, the brand name is Vivitrol, before they leave jail or prison. And that's been shown to decrease the likelihood of overdose because of the risk of return to use once they've left the jail or prison. We've seen that increasingly moms are interested in Vivitrol. Perhaps they've used methadone or buprenorphine, and they haven't been successful, but they have been successful with Vivitrol. We do offer it with the caveat that there's limited but emerging safety data, and there are certainly fewer short-term neonatal effects from the data that we have available that is very limited.
Marcela, I'm just going to say
5 minutes?
Yep.
Okay, I will fly. So medication for opioid use considerations for pregnant and postpartum women. Decreasing the dose does not decrease NAS or NOWS. So we have many providers that are very well intentioned and try to say, well, try to keep your dose as low as possible so the baby doesn't have withdrawal symptoms. Not how it works. So not focusing on the dose is really important. The thing that is correlated with neonatal opioid withdrawal syndrome is the amount of tobacco that folks are consuming. So if we're going to focus on one of the substance use disorders, and about 80% of women who have opioid use disorder have a co-occurring nicotine use disorder. And then the most important thing to focus on is really maternal stability. So factors for return to use among pregnant and postpartum women. So what we know is that 80% of women who were abstinent in the last month of pregnancy will have a return to use to at least one substance in that year postpartum. The question to answer for what destabilizes moms is my baby going to get taken away? All right, so this is the question that we really need to answer. And sometimes the answer for a return to use is yes. And actually, Utah has one of the highest rates of removals for substance use. And we know that white children are removed from from parental custody at much lower rates than Black or American Indian children. This is not specific to substance use, but we also see that in the in removals of custody for substance use. The number one cause of death in pregnancy and postpartum in Utah and across the country is drug related. So either accidental drug related overdoses or suicides that are drug related. And so really it's that year postpartum that we need to be watching, folks. We do see overdoses and suicides in pregnancy, but at much lower rates than in pregnancy. The things we want to watch out for are undiagnosed mental health issues, untreated chronic pain. If there is a removal of custody, that is a huge trigger for return to use. Lifetime sexual, emotional, and mental abuse, and whether there are previous overdoses or suicide attempts are major risk factors for death in the year postpartum. And this is just to drive home that point that it's that year postpartum that is the most important time to be paying attention to these moms and babies. What we know is that at the provider level, there's a lack of understanding of addiction care basics up to and including starting medications for opioid use disorders. And that's related to education, the way that we were taught in our respective trainings. And that's changing currently with our learners now. But many of us that are already out there practicing receive very little education care. Providers are often uncomfortable in caring for pregnant and lactating individuals and may give well-meaning but misguided advice like you should taper your medication so your baby is not affected. And we know that's the way that often moms, once they hear one provider say that, that really sticks, like I'm going to cause harm to my baby. Facilities, the facilities level, there's really a paucity of treatment centers for pregnant and parenting individuals. And then at the systems level, we know that there's loss of insurance in that year postpartum, particularly for Medicaid patients, is a major risk factor for return to use. I will skip trauma-informed understanding, intimate partner violence, and co-occurring mental health disorders, which are also major triggers for returns to use. So summing it up, substance use disorders are a chronic treatable medical condition of the brain. Substance use treatment is available. The caveat there is for pregnant and postpartum individuals, it's often evidence-informed, not evidence-based, because women are systematically excluded from studies that we do on substance use treatment, and we are working on changing that. Addiction hijacks the brain, and pregnancy can hijack it back, but addiction may hijack that brain back in the postpartum period, which is really the most critical time. And then stigma and discrimination are woven into many facets of care for women with substance use disorder and may contribute to a return to use. Okay, there is my email. We have time, I think, for questions. Is that right? Okay, we have time for questions. Like I said, it's not that you can't email me on Tuesdays. That's when we have Super Rad Clinic, and I just don't read emails on Tuesdays. And so it'll take me often at least a week to catch up to those emails. So if you ever have a question, please email me. If I haven't emailed you in 3 days, email me again. Okay, questions.
Marcela, this is Janelle, and I have one question for you. I loved your topic where you're saying that postpartum year is the most influential year, which is when a lot of the families are in early intervention. What is one thing as an early intervention provider that we can do to help support the moms and families in that time?
So great, that's a great question. So one thing I would say is an understanding that return to use is part of the cycle of addiction, right? And it happens, it's something, and it doesn't necessarily mean that there is abuse, right? And I think that that's a really important distinction that we need to make, that child abuse and neglect are one thing, and substance use is another thing, and they are not the same thing. And really talking to parents about, well, what are the circumstances if they have a return to use, reaching out to providers that understand this, and then making plans for, if I'm having, I've had a return to use, how do you assure that your child is safe? Right. So there are major safety concerns. I don't mean to say that there aren't safety concerns, but really being proactive about saying, if you're having cravings, if you're in an environment where you're feeling like you're starting to become unstable, having inviting them to share that with you, and then knowing what to do with that information, which is really referring them to treatment. I put a website in the chat at the beginning. There's a link to the public health website for mom baby resources. Another really great resource is our Division of Substance Use and Mental Health. And they will link parents up with treatment for pregnant and parenting individuals.
Great, thank you.
Any other questions?
Marcela,
Yes.
I thank you for your presentation. Can you talk a little bit about where many moms and babies are following up after delivery?
Yes. So, the one I will, talk about the most is the Super Rad Clinic. And so we follow moms for a year postpartum at least. And so we don't, those 6 weeks. So I am 3 months postpartum, and I like getting out of the house with pants on. And for 6 weeks, I have a new appreciation for that. And it just has further reinforced that really that year postpartum, you are just coming out of that fog at 3 months. And that's part of the reason why we've made that decision to really keep moms for at least a year postpartum as they're adjusting to the stresses of having a new baby, as they're adjusting to sleep deprivation, potentially postpartum depression, the financial stress of having a baby. I mean, those are all things. DCFS involvement, just having DCFS involvement is a major stress. So following up, certainly in super rad clinic, we keep them for a year. Not everyone can come to us, right? Because we're at the U and we're just one clinic, but we are increasingly setting up a network of providers that have this understanding about pregnant and postpartum women. And where they can follow up. The CHC is one option, so the community health clinics. Those are primarily family docs who are well-trained, have buprenorphine waivers, can do prescribing. And then often we get questions about things like, well, you know, maybe it's not opioid use disorder, it's methamphetamine use disorder, right? And that's one of the, we have a huge epidemic of methamphetamine use here in the Intermountain West. And there are no effective medications. And it is the crux of treatment is behavioral therapy. So following up with every county is a little bit different, but those following up with treatment providers in the counties. I know that's a vague response, but finding whatever local resources you have, and we can often link you to folks if you have questions. And then the babies follow up in our bridge clinic if they are treated here if it's a mom baby dyad with opioid use disorder. It's a bridge clinic at the university that it's meant to be a transition clinic to really educate and support moms and babies and to keep those babies out of the hospital. Great questions. Any other questions?
Not seeing any in chat, and we'll let everybody take one more minute to see if any questions come up.
I have one more question just from the primary care, the pediatric perspective again. So I heard you say that tapering the dose for moms during pregnancy doesn't really impact the likelihood of or the severity of the baby's now symptoms. Does it matter, in terms of, is the dose matter at all, or is it just that tapering is not effective?
Dose doesn't, from a population level, dose does not appear to affect NOWS, the likelihood that a baby will have withdrawal. And we see, so I can't say, so what do I mean by that? When we pool the available data that we have, there isn't a correlation between, at 40 milligrams of methadone, your risk of NOWS is this, and at 100, it's this. It just doesn't work like that. So I've seen, for example, the moms on very high doses of methadone and their babies don't have withdrawal symptoms. And I've seen moms on pretty low doses of methadone and their babies have withdrawal symptoms. And it's probably from several things. One is metabolism, right? So mom's metabolism, dad's metabolism, placental metabolism, and the newborn's own metabolism. The other co-occurring substances, so tobacco is one of the major drivers of risk of neonatal abstinence syndrome. And then if there's psychotropic medications on board, so for example, antidepressants may increase that risk, but we would never suggest that someone should come off of their antidepressant in order to mitigate the risk of neonatal opioid withdrawal syndrome. So we don't focus on the dose at all. We focus on maternal stability. The things to do on the back end from a pediatric perspective, right? So rooming in is one of the most evidence-based approaches in the hospital, where it's really skin to skin, breastfeeding, low stimulation environments, that decreases the risk of neonatal abstinence syndrome. And that's a systems thing that we can do to provide that care beyond when mom is discharged. So many hospitals in Utah, their babies that are experiencing withdrawal syndromes are managed in the NICU. And here at the U, we're really lucky that we are able to provide rooming in. So when a mom is discharged, she stays, the room converts to the baby's room, and they stay in paired care with the support of nursing to really be able to decrease that risk.
Great. Thank you, Dr. Marcela Smith, for your wonderful presentation and all of that great information. I'm going to have you stop sharing, and I am going to let Tressa Johnston, who is presenting our case today, take it away. about.
Okay, thanks. Thanks, Janelle. Hang on here. There we go. And I'm Tressa Johnston. I'm a physical therapist with the Weber Morgan Early Intervention Program. The case that I will be presenting is regarding a 17-month-old child who was placed in foster care the day after delivery due to mother's substance use. The child was in the NICU for 5.5 weeks for withdrawal.
We can't see your slides,
Oh,
Tress.
sorry.
Sorry.
Let's see here. Okay. Is it sharing now?
Yes.
Okay, is it still sharing?
Yep, you are good now.
Okay, so I am Tressa Johnston, a physical therapist with Weber Morgan Early Intervention. I've been worked in the pediatric physical therapy field for over 27 years, and the case that I'll be presenting today is a child who was placed in foster care after delivery. Again, the biological mother tested positive for multiple medications, including barbiturates, methamphetamines, and nicotine. NAS is an automatic qualifying diagnosis for early intervention. If you're unfamiliar with early intervention is a program that works with families and children in their natural environment. We are a parent education, parent coaching model that strives to teach parents and family strategies they can implement on a daily basis as part of their routine or play. The primary areas of concern in this particular case are gross motor skills, including movement patterns and balance, along with expressive and receptive language, meaning that the child has limited babbling, using few words, poor imitation skills verbally and non-verbally. Some goals include improving balance with walking, so the child would be able to walk 50 feet on an uneven surface without loss of balance. So that's talking about outside on the grass or walking from the carpet, being able to transition the carpet to solid wood, solid surface floors. Improve transitions from standing to squat with their arms supported on a table or couch or furniture. Increasing imitation of new sounds or gestures, and using 5 new words or signs daily during interactions with family. Some of the barriers concerning are perhaps language apraxia and poor graded muscle control with stand to squat transitions. Additional information, expressive and language strategies that have been instructed are to imitate child sounds and gestures to facilitate turn taking. So family members imitating the child sounds and attempting to facilitate turn taking and reciprocation of sounds or different sounds. Family members labeling items, whether it's bottle versus using words like this or that in trying to point and understand what the child is wanting. And also incorporating siblings into the games and play, and encouraging them to not communicate for the child, but teaching them the strategies that we are teaching the family. Gross motor skills that we are using are including, we're working on some higher level skills. So putting couch cushions or pillows or rolled up towels or blankets in hallways for the child to navigate or step over. They can use the wall to help them by using a hallway. It limits their ability to go around the object, and it's a fun way to incorporate siblings. going for walks in the yard, holding hands, picking up rocks and sticks and all those fun things and putting them in a bucket or basket, and playing games to work on those transitions of sit to stand. So sitting on parents' lap and then standing up to throw toys in the tub as part of that routine. Again, NAS is an automatic qualifying diagnosis for early intervention. So when children have a diagnosis of NAS and are referred to early intervention services, they automatically qualify to receive those services. Some other strategies to facilitate language and tips for the family who is adopting other children. There's a lot of stress there, and techniques to help with siblings that are having tantrums of a young age.
Okay, so we're going to do breakout groups. And so based on those conversations, if we can provide some ideas about strategies to facilitate language, how to help with family stress of adopting 5 children. Wow. Yeah, and then any techniques about siblings tantrums. I'm going to give a few minutes to ask any additional questions of Tressa before we go into breakout rooms.
So this is Kurt Phillips. I've got a question, Tressa. The other children who are being adopted, have they also been affected by substance use?
Yes, they are also being, they're coming from the same home.
Okay.
So they are all siblings.
And do we know anything about the dad?
No, I don't have any information regarding paternal. One of the things that I wanted to share as well is a lot of times the kids that we have seen that have had the exposure to substances, their movement patterns, they tend to have the hypertonia or that extensor movement pattern. And so a lot of times these babies look actually pretty good on their tummies because they're holding their head up and they appear to have really good head and trunk control. What we find is that they have an imbalance in their ability to modulate and to coordinate flexion movements. And those flexion movements are needed to be able to roll from their back to their tummy, and with sitting and propping on their hands and crawling and transition. So that's something to think about when you see them and they look like they're doing well with tummy time, is you can try some supported sitting. And babies usually you can put them into like a ring sit position. So there's some flexion in their legs and they'll sit there as you support them. And a lot of times these babies will have a harder time there, and instead they want to extend their legs and kind of push back into like laying on their back. So, as early interventionists, as OTs or PTs, we can work with the families coming up with strategies that will work for the baby and the family on how to integrate and coordinate those flexion movements. That co-contraction between flexion and extension is really important in development of gross motor and fine motor skills.
Okay, well, great. I'm going to put us all into breakout groups. There is a hub member in each breakout group that will facilitate the conversations, and then we will come back in about 20 minutes.
Real quick, sorry. Have they had the baby since the baby was born?
The baby was in a previous home and then has moved to a different foster home that is in the process of the adoption.
Okay. How long have they been in this home for?
Several months.
Hi, everybody. As you're coming back on, if you'll just take a few minutes and answer those poll questions. And then we are going, as everybody continues to join back in, we'll go over at least one idea from each of the groups. And I think that, Natalie, you're here, right?
I'm here, yes. Is that what you
I
said?
was just trying to make sure I had everybody back and I could see your face, and it said you hadn't joined the main meeting yet. So that's what I was double checking. But since you're up full on my screen, do you want to share or call out who your speaker was from your group?
Also moderated. I didn't even do that. We didn't assign anybody.
Okay, well,
So
what's
it's
one
Tressa.
idea from your group, Tressa?
Yeah, we talked about making sure that there had been maybe an ENT referral, and also considering the age and some of the other language skills, like looking at maybe the MChat. Also, we talked about incorporating kind of signing and really using maybe some swinging in a blanket or some other incorporating kind of movement or the vestibular system, whether it's holding the child and dancing or putting them in a blanket and swinging, kind of seeing if we can prompt some other signing. We talked about also some massage and incorporating that with trying some language, or just looking at some of those struggles of the transitions. We also talked about kind of addressing siblings and giving, like older siblings, giving the sibling themselves kind of a job that is related with the child, their play job, as far as like doing an activity, and seeing if that also, those siblings can be the best therapist. And we also talked about, as far as like a special activity for the younger kids that are struggling with the divided attention. So during therapy sessions, that there's a special activity that maybe they don't get to do all the time, whether it's Play-Doh or coloring, or if there's a home visit, taking a coloring book in for that child, and kind of encouraging them to make a picture or something for me or for mom while we're there. And we talked about looking at kind of parent skills on redirecting those tantrums, and how those tantrums really can be a way to a sense of control, and whether they get positive or negative reinforcement, it's still attention, and that behavior, that is something the child can control when maybe control has been unreachable.
Those are great ideas. Kurt, what about for your group? I don't know who you assigned.
Well, I kind of didn't assign anybody, so it'll be myself. So with regard to the language, we talked a lot about repetition and using even using songs or music to do it. So taking a familiar song like Twinkle, Twinkle, Little Star, like John, now you did a good job today, or do whatever we do to try to help encourage that language while we're doing physical therapy activities or other activities. Okay, sit to stand, it's time to stand, things such as that we could utilize to help the child be able to hear some words, sit to stand while doing the same activities. Talked about narrating. I thought this was really interesting, narrating what's going on during the day, kind of like a play-by-play in sports. So you'd be talking as you go out to the car. Okay, now we're going to go to the car. We're going to get in our car seats because we're going to the grocery store, and narrating for that child, so that during these physical activities of walking to the car and getting in the car and climbing in that they would have the language input as well. With regard to the multiple children, one of the things that one of our folks talked about was the importance of making sure that other children know kind of what triggers are or what the needs of their siblings are. So if one of the siblings hates a lot of loud noise, to make sure everyone else knows that, so that, when they're going to be loud, maybe there's a place that they can go to be loud, or a place that the other person can go to be quiet. And then also, I thought a really good suggestion, when you have multiple kids, period, sometimes you need just a little bit of therapy, a little bit of counseling to help you as a parent be able to deal with the stresses and the I guess the difficulties that come along with having multiple children, especially if you have multiple children with any sort of challenges with sensory or that type of stuff. We talked a little bit about tantrums. There was something that was shared about a red step, with a place where they could go and sit and think about what they could have done better, and then come out of there and make the better choice the next time. So that
Yeah,
was
those are great ideas. I love narrating. Narrating is a great way to really promote a lot of language and help with those transitions too, from one activity to another. Yeah, those are really great suggestions. I wrote many of them down, and incorporating music can definitely be something that's age appropriate and that kids love.
You just got to make sure you sing better than I do. And I will put all of these in the suggestions. It'll be in the Canvas eventually, Tressa, so you can pull them out of there as well.
Great,
So,
thank you.
That wrapped up our time. And so Sue, your group, sorry, doesn't have time to share one idea, but everybody will send in their recommendations to projectscope@usu.edu. So Natalie and Tressa and Sue's group and Kurt's group, send those in, and we will compose those. Tressa, you'll get a report of it that will also be shared on our Canvas site. Jared, are you still on the call? And we'll go over really quick about CMEs one more time. There was one question about that.
Yeah, happy to entertain any questions. I have sent an email to everybody who's pre-registered and anybody whose address I had and could look up. So if you have not received an email about CME, go ahead and reach out to Janelle. Janelle can reach out to me, or just reach out to me directly here at this email address. The short answer here is watch that email and claim credit no later than midnight tonight. That is critical that you do it today. And I'll be available here for the next 2 or 3 hours at my computer to answer emails if there are questions. It's really simple, but you do need to you do need to open a profile with USU Health CME office. So that's the essentials. If there's questions, please reach out by email.
Great, thanks. And then be sure to look for those surveys that are coming from our Red Cap. And when you get those filled out, you will also get a certificate of attendance from our groups. So our next session is August 18th. And we are having Heidi Peterson from the Department of Health talk to us about kind of prevention factors related to opioid use. So we'll look forward to seeing you guys then. Have a great rest of your day.